adjuvant in poor responder. First, I have taken this from the Gardner textbook of assisted reproductive technology. Now, first we'll talk about what is poor responders. Who are poor responders? Okay, they're patient who don't respond well to controlled ovarian stimulation, which means their ovaries don't produce enough eggs during the procedure. Don't respond well, okay? Does not produce enough eggs during the procedure. Now, what is its significance? Why is this a problem? Because it leads to less number of eggs and poor quality embryos and overall lower chances of pregnancy. This is a big challenge in the fertility treatment. What is the prevalence? Prevalence is around 9 to 24% of the patient undergoing ART are poor responders. So this is something we came across quite often. It is not rare. It is quite often in fertility clinic. What is the goal of adjuvant? Goal of adjuvant is to improve ovarian response, how ovary respond, to improve that. Okay, second is to enhance quality of eggs. Third is to increase the chances of pregnancy. These are the goals. Now, why adjuvant are needed? Okay, we'll talk about why adjuvant are needed. Adjuvant are like supporting treatment that help in improving the chances of success in ART. See, let's understand this. If a patient has low ovarian reserve, see, reserve is low. Okay, if a patient has, this is ovary, reserve of the bilateral AFC is low ovarian reserve. When the woman has fewer egg in her ovary, adjuvant helps to stimulate more follicular growth so that more egg can be retrieved. See, we saw this patient has a low AFC. What will provide the adjuvant? Will provide the adjuvant so that it helps stimulate more follicular growth. Now, after giving adjuvant, we'll see the ovary will have more follicles. Okay. First is this. Second is poor egg quality. So, what adjuvant do? Adjuvant help to improve the mitochondrial function. This is mitochondria in the cell. The adjuvant will improve the mitochondrial function so that mitochondria is the powerhouse. It provides the energy. If energy is not good, egg quality won't be that good. So basically, adjuvant help to improve mitochondrial function in the egg and reduces oxidative stress. This makes the egg quality better. Then third is endometrial receptivity. Third, why adjuvant is needed is for endometrial receptivity. Sometimes the uterus is not prepared for implantation. Adjuvant can improve the uterine environment, making it easier for the embryo to attach. Example, if a woman is having thin endometrium, it might benefit from a adjuvant to make her uterus more receptive for implantation. Okay. We can give growth hormone for this thin endometrium. Okay. So that it will become more receptive. The endometrium will become more receptive, more welcoming. Okay. Now, strategies to treat poor ovarian response in ART. What are the strategies? First is increase the number of recruitable follicle. See, there is a reservoir in the ovary. In the ultrasound, we can only see the follicle above 2 millimeter. Will recruit means those follicle greater than 2 millimeter is the recruitable follicle. but less than 2 millimeter, which we cannot see by ultrasound, are non-recruitable follicles that are act as a reservoir. So by giving adjuvant, even those reservoir will come till 2 millimeter and will be recruitable follicle. We can even recruit those follicles. So the recruitable follicle, amount of recruitable follicle will increase. First function is to increase the number of recruitable follicle. Okay. Second is recruit all available follicles. See, in day 2, we'll see the ovary. Like we have this much of follicle. Now, adjuvant will help in recruiting all the follicle, means it won't let any follicle atretic. All the follicle will be able to give an healthy egg in oocyte retrieval. Otherwise, without adjuvant, some may get atretic. Okay, but adjuvant will help to recruit all the follicle till the oocyte retrieval. So we can get a healthy egg from all the follicles. Okay, third is improve oocyte quality. Will enhance the mitochondrial function and it will decrease the reactive oxygen species. Now we have, see, this is the strategy to improve ART outcome. See, as we can see, without adjuvant, there were only 3 follicle which we can use in the cycle. But after giving adjuvant, we have so many follicles that can be given in the cycle. See, second point is all the follicle which we have recruited from the reservoir will form a good follicle. First, see, this red cycle is without adjuvant. See, only 3 follicles were present for oocyte retrieval. But here in blue, we see after adjuvant. After giving adjuvant, this blue one. After giving adjuvant, so many follicles are present for, follicles are present for oocyte retrieval. Okay. And next is oocyte quality. Third is oocyte quality. What adjuvant does is it improves the oocyte quality. Now, ethical consideration. See, whenever adjuvant are used, certain ethical consideration must be addressed. Patient need to be fully informed about the cost of the treatment. See, ART is expensive and adjuvant can add to the cost. Patient should know this before that adjuvant will cost extra. Okay. Second is experimental status. See, some adjuvant may not fully proven, are not fully proven. Patient need to know if the treatment is experimental. Third is the evidence for efficacy and safety. Patient must understand how effective and safe the adjuvant is based on the current strategies. These 3 patients should know. See, classification of, we'll see the classification. First is androgen, second is growth hormone, third is antioxidant. Androgen, there are 2 type of androgen, testosterone and DHEA, dihydroepiandrosterone. What is the now growth hormone and antioxidants? What are the antioxidants? CoQ10, then melatonin, then L-arginine, then vitamin E, vitamin D, selenium. Vitamin D class I have already taken. Selenium, myoinositol, D-chiroinositol, carnitine, vitamin B complex, vitamin C, folic acid, omega-3 fatty acids. So first I'll talk about androgens. Androgens, what is the mechanism? Androgens will increase. Basically, I'll talk about mechanism later. First, I'll just revise it that androgen will enhance the follicular responsiveness to FSH and improve the ovarian stimulation outcome. What will growth hormone do? Growth hormone will boost IGF-1 production within the ovary. Growth hormone will boost IGF-1 production within the ovaries. This support follicular development and improve the quality of oocyte. Okay. Then antioxidants. What will antioxidants do? It will reduce the oxidative stress and protect the oocyte from damage and improve overall oocyte and embryo quality. What are the key challenges in poor ovarian response? See, there are two factors, intrinsic factors and extrinsic factors. What are intrinsic factors? Intrinsic factors is challenges what are that it has already has low ovarian reserves. ठीक है? And the quality, first is ovarian reserve is low, second is oocyte quality is bad, like due to aging or oxidative stress, and third and or mitochondrial dysfunction is present. Oocyte reserve is low, oocyte quality is bad. Reason for oocyte quality can be mitochondrial dysfunction, and mitochondrial dysfunction is present. Okay. Then second is in extrinsic factor. In extrinsic factor, either the stimulation which is given is suboptimal. Stimulation which the dose of the stimulation which is given was suboptimal. Or the follicular environment is suboptimal, means there is oxidative stress, and there is low androgen level. What are the clinical challenges? Limited oocyte retrieve. So there will be limited oocyte retrieves, poor embryo quality, a high cancellation rate. Key goal is address intrinsic deficiencies and optimize stimulation protocol for better ART outcome. We'll have to see the intrinsic deficiencies. What are the deficiencies? If mitochondria is okay, if ovarian reserves is okay, we'll have to see that. And according to that, we'll have to plan the protocol. Okay. Now androgen. We'll talk about androgen. Role of androgens in folliculogenesis. What is the role of androgen in folliculogenesis? See, role in early follicular development, responsible for proliferating granulosa cells. See, okay, androgen is proliferating granulosa cell, which is essential for follicular development. Second is androgen increases the production of insulin-like growth factor 1. Insulin-like growth, which is in which enhances the early follicular growth by creating favorable environment for follicles to develop. Okay, this will enhance the early follicular growth. Now increase in follicular number. See, first we talked about what it was doing to early follicular development. Second is what is it doing to the follicular number. Androgen increase the number of growing follicle, like there are pre-antral and antral follicle. Excess androgens help enhance the growth of smaller follicle like pre-antral antral, ensuring more follicular recruited during the ovarian stimulation. So we'll, after giving androgen, we'll see on second day ultrasound and we'll find more follicles in the ovary. Okay, so it has increased the pre-antral and antral follicular growth so that we can have more follicle during the second day, which will stimulate and get our oocyte in after oocyte retrieval. So on second day we basically do ultrasound and we see the follicles, how much follicles. So it has actually recruited from the reservoir. Androgen has helped us to recruit more follicle. So on second day of ultrasound we'll see more follicle. Okay. Second is FSH receptor augmentation. So androgen improve the expression of the FSH receptor on the granulosa cell. This makes the follicle more responsive to FSH stimulation. Okay. See, basically, if a woman, like there is a woman who has suboptimal response to stimulation drug, now we'll do androgen supplementation in that woman. Now her granulosa cell will have FSH receptors. So she'll become more responsive to FSH, responsive to FSH. Now we'll talk about the clinical evidence of androgen effect. See, in PCOS patient, naturally high androgen levels are there. So they have increased follicular number. Okay, second example is testosterone in treated individual. See some studies, like if you want, if like a transgender is there who want female to male transition. So in these kind of person, we give testosterone therapy. We give exogenous testosterone. So we saw that these kind of patient has more follicles in the ovary after the testosterone therapy. Okay, more follicular in the ovary after the testosterone therapy. Implication of suboptimal androgen level. See, implication of suboptimal means when androgen levels are low, it can negatively affect the ovarian response. First, it will decrease the sensitivity to FSH. Sensitivity to FSH will be decreased. Without enough androgen, FSH receptors are reduced, leading to a poor ovarian response during stimulation. Second is lower ART success. So basically, if there is a suboptimal androgen level, there will be reduced pregnancy outcome in ART. There will be poor response to ovarian stimulation and reduced pregnancy outcome in ART. See here, if the diagram, we can understand that in primordial follicle, early follicular growth, it is helping androgen by producing IGF-1, increasing IGF-1 and IGF-1 receptor in primary and primordial follicle. Okay, in preantral follicle, it is increasing granulosa cell proliferation, increasing IGF-1 receptor, FSH, follicular stimulating hormone receptor, increasing sensitivity to FSH, and increasing anti-apoptotic pathway. It does not let the follicle to get atretic or apoptotic. Okay, because it is increasing the anti-apoptotic pathway. Then in antral follicle, it will increase the number of antral follicle. Like I have already told you that when we'll do on day 2, second day, to see the ultrasound for the stimulation, if we'll see, we'll find that there are more number of follicle because of the androgen. So it will increase the number of follicle, increase the follicular growth, and this is same as the preantral follicle. It will increase the response to FSH in pre-ovulatory follicle. Oocyte maturation will be more, ovulation rate will be more, number of corporal lutea will also be more. Now we'll talk about DHEA. Okay. This is a hormone that acts as a precursor to testosterone and dihydrotestosterone. Okay, these testosterone and dihydrotestosterone are important androgen. It is naturally produced in the body, but its level peak during the third decade of life and decline with age. It plays a crucial role in ovarian function and follicular development. Now, production. It is mainly produced by the adrenal cortex. Okay, DI is mainly produced by the in the zona reticularis and also in the gonads and brain. Nature of DHEA is it is a weak androgen, weak binding to androgen receptor, precursor for potent androgen. I have already told that DI is a precursor for potent androgen like testosterone and dihydrotestosterone. DHEAS characteristic. This DHEAS is sulfated metabolite. This is most abundant form, stronger albumin binding and longer half-life, 10 to 20 hours. Okay, this is most abundant form, stronger albumin life and binding and longer half-life. Serum concentration, I have already told that it peaks in third decade of life and declines steadily thereafter. After third decade, it declines steadily. Binding in circulation, 5 to 10% are bind to SHBG. 3 to 5% are free, and most of it is bound to albumin. Most of it is bound to albumin. Effect of oral DA: increase testosterone, DHT, dihydrotestosterone, IGF-1 level, enhance FSH responsiveness to granulosa cell. As we already know that DI is a dihydroepiandrosterone, is a androgen. So basically what we have talked about androgen, all those things will be done by DIA. So mechanism basically FSH receptor upregulation. We have already talked. DIA increases IGF-1 level, making granulosa cell more responsive to FSH. It also helps in follicular recruitment, granulosa cell proliferation. It helps in reduction of oxidative stress and support for ovarian steroidogenesis. So androgen act on the intra-ovarian environment, reducing oxidative stress. In now for ovarian steroidogenesis, this enhance the ovarian steroidogenesis, improving the production of estradiol, which is vital for follicular growth. DIA basically, see, DIA basically change into androstenedione with the help of, I think, 3 beta HSD. What I remember is 3 beta HSD. Then androstenedione is changes into testosterone with 17 beta HSD. Okay. Now this testosterone and androstenedione, this all happens in theca cell. Now this will go to the granulosa cell, and here they will form estradiol with the help of aromatase enzyme. And this estradiol is vital for follicular growth. So DI is converted in the ovary theca cell into the potent androgen, which is what potent androgen? Androstenedione and testosterone, which is are also used for estrogen production. So basically, pregnenolone is converted into DIA. Pregnenolone is converted into DIA, and DI is converted into androstenedione with the help of 3 beta HSD. 3 beta HSD, and androstenedione is converted into testosterone with the help of 17 beta HSD. And this testosterone goes to the testosterone and androstenedione goes to the granulosa cell and change into estradiol with the help of aromatase, and this is vital for follicular growth. Key outcome: improved follicular response to gonadotropin during stimulation and increased number of high quality oocyte retrieved in the ART cycle. Now we'll talk about the dosing of DIA. Dosing is 25 milligram orally 3 times, basically 75 milligram per day. 25 milligram, 25 milligram, and 25 milligram. 3 times. Duration: administration for at least 8 to 12 week, means basically it is administered for 3 month, 12 week. Okay. Before starting COS, control ovarian stimulation, timing is should begin at least 2 to 3 months before stimulation to align the follicular recruitment. Same thing it is saying. Spatial consideration: start early to ensure incorporation into the follicular cohort for upcoming cycle. We have to start it early. Dear side effects, like the dose we use in ART, there are no side effects. We use 75 milligram, so there are no side effect in such a small dose. Okay. But due to overuse, if we'll overuse, are mostly temporary and mild. The side effects are mostly temporary and mild, and they include oily skin, acne, and hair loss. All three are immediately: oily skin, acne, and hair loss. All three are immediately reversible. These are all reversible with lowering of DR doses. As soon as we lower the doses, if we are over doing, we are eating more DIA and we lower the doses, these like oily skin, acne, and hair loss will get reversible. Okay. All three are immediately reversible with the lowering of DR doses, usually 25. This already what we give in ART is very low doses. So basically there are no side effect with that much of dose. See, steroidogenics of androgen and estrogen, it is already given. What I have already told, this pregnenolone with 17 hydroxylase enzyme is converted into 17-hydroxypregnenolone, and with 1720 lyase, it is converted into DHEA. Pregnenolone is basically pregnenolone is converted into DHEA. Now this DHEA, with the help of 3-beta HSD, it is converting into androstenedione, and this androstenedione is converted into testosterone with the help of 17-beta HSD. Okay, now this testosterone and androstenedione will go to the granulosa cell and will change into estrogen, which is essential for follicular growth. See this it is already shown here. This is going to the, this is with the help of aromatase. This androstenedione and testosterone is converted into estrone and estradiol. Basically, androstenedione is converted into estrone and testosterone is converted into estradiol. Okay. Now, preferred patients for androgen. What patients will prescribe androgen? In what patient will prescribe DHEA? Will prescribe DHEA in low ovarian reserve. Okay, patient with diminished ovarian reserve, like low AMH, less than 1.1 nanogram per ml AMH, or low AFC, less than 5 to 7 AFC. Poor responders. First is low ovarian, ORT crab. Low ORT, ovarian reserve testing, is less, low ovarian reserves are there according to ORT. Then poor responders. Poor responders according to either meeting the Bologna criteria or Posidian group with low follicular output. The FORT, follicular output rate. Okay, so low follicular output rate mein we are using this androgen diaz. Okay, so low follicular output rate means what? See, these are the AFCs. AFC we'll see on second day of the cycle. These are the AFC which are between 3 to 8 millimeter at the baseline. The follicle which are measuring 3 to 8 millimeter at the baseline, and we'll keep this in a denominator, and in numerator there will be 16 to 22 millimeter on the day of HCG trigger. How many follicles are there which have diameter of 16 to 22 millimeter on the day of HCG trigger? On the day of HCG trigger, divided by the AFC on the day of second day, means the 3 to 8 millimeter diameter of the follicle into 100. Okay, so basically if it is 30%, less than 30%, means it is having a poor response. If the group has 100 AFCs, only 30% is growing into a dominant follicle, which can be changed into the oocyte after oocyte retrieval. Okay, only 30% can be retrieved through oocyte retrieval. Other preferred candidate are older women. As we have already discussed, the androgen after certain age start declining. So older women, especially aged greater than 35 years, particularly those with declining androgen level, which can affect the follicular dynamics. So older women are also the preferred candidate for DHEA administration, DHEA adjuvant. Okay, why not recommended in patient who are hyperandrogenous, like PCOS patient, or whom already the androgen level are elevated? We won't give the supplementation of androgen. And in unexplained fertility, where already there is a normal ovarian reserve and there is no history of poor response to the stimuli, we won't give them a DHEA or androgen. Unexplained infertility who have normal ovarian reserve and no history of poor response to stimulation, we won't give them. Okay, so the 2020 ASHRAE guidelines state that the use of DHEA before and during ovarian stimulation is probably not recommended for poor responder until further evidence become available. According to ASHRAE, we need more studies. Now we'll talk about the testosterone as the adjuvant for poor responders. Okay, mechanism of action. First, we'll talk about the mechanism of action. First is FSH receptor sensitization. The testosterone upregulate the FSH receptor, enhancing the ovarian sensitivity to FSH. Second is follicular recruitment. See, if there are only 3 follicle on second day, now after giving testosterone, we'll recruit more follicle on the second day of doing ultrasound when we want to give the stimulation. Then enhanced steroidogenesis, the same thing as we have already discussed. Testosterone will go into the granular cell and will convert testosterone into the estradiol with the help of arome enzyme. Okay, this estradiol is very critical for good follicular growth. Fourth is reduction of oxidative stress. Okay, this will enhance the microenvironment, intra-ovarian environment for oocyte to grow. Then reduced apoptosis. This also we have discussed. If we'll reduce apoptosis, so less atresia will happen and more follicle for oocyte retrieval will be present. Now, what are the sources of, see, in DHEA, most of the DHEA come from zona reticularis of adrenal. Zona reticularis of adrenal means 50% of DHEA is coming from the zona reticularis of adrenal. Okay, zona reticularis of adrenal, 50%. 30% is coming from DHEAs, and DHEAs is 100% coming from zona reticularis of adrenal. Now 30% is coming from this DHEAs and only 20% is coming from the gonads. Only 20% of DHEAs is coming from the gonad. Now we'll talk about the testosterone. Testosterone, 25% is coming from the ovary, 25% is coming from the adrenal, and 50% is coming from the androstenedione. 50% of the testosterone is coming from the androstenedione. And now we'll talk about the binding and availability. See, only 2% is available free testosterone in female. 66% is bound to the SHBG and 30% is bound to the albumin. Now, dosing of the testosterone. See, transdermal testosterone gel or patch. Okay, these two forms basically testosterone available, gel or patch. These are the most common form. These methods avoid first pass metabolism and prevent elevated hepatic concentration of oral testosterone. In these methods, first pass metabolism will be avoided. First pass metabolism will be avoided in this method and prevent the elevated concentration. Matlab it won't go through the hepatic. Okay. It prevent the elevated hepatic concentration of the oral testosterone. Now dose. What about gel? Gel is 1% and dose is 10 to 12.5 milligram per day. Okay, 1% concentration is used in the most studies. Now, what is percutaneous absorption? Percutaneous absorption is only 9 to 14%. And these levels are stable because of avoidance of first pass metabolism. What about patch? What about patch? Patch is a 2.5 milligram testosterone patch was administered for the 5 days in Belesh et al. Prior to stimulation. This resulted in a decrease in the incidence of poor response despite using lower doses of fertility drug. Now duration basically this gel mostly we use this gel and the duration is 21 to 28 days before starting COS, control ovarian stimulation. Longer duration like 3 to 4 week duration shows better outcome, but evidence is still not uniform. And monitoring baseline and follow-up androgen level, example testosterone and DHEAs, to avoid excessive androgen exposure. वैसे with this much of dose there is nothing, side effects are not much. Then how to use androgen 1% pump. See, what will we do? Androgen, testosterone, androgel is there. Androgel, testosterone gel 1% for topical uses, available as a metered dose pump. In that, each pump delivers 12.5 milligram of testosterone in 1.25 gram of gel. Means this is 1.25 of in one pump we get 1.25 gram of gel, and in that 12.5 milligram of testosterone is present. Okay. So before using a new bottle of androgel 1% for the first time, you will need to prime the pump. How will we prime the pump? To prime the pump, androgel 1% pump, slowly push the pump all the way down 3 times. Okay, 3 times we'll have to push the pump. Do not use any gel which has come out. We don't have to use that. Do not use any androgel 1% that came out while priming, during priming. Like when we open a new metered pump, we do first priming, and we don't use anything which comes out of priming. How priming is done? Priming is done by pumping it 3 times. Okay, 3 times we'll have to slowly push, and we'll have to discard the gel which has come after the priming. Okay, wash it down the sink to avoid the accidental exposure to others. Now your androgel 1% pump is ready to use. Okay, remove the cap from the pump, then position the nozzle over the palm of your hand and slowly push the pump all the way down. Apply androgen 1% to the application site. You should use 12.5 mg, one press of pump of androgel 1% daily for 3 weeks prior to starting stimulation. Okay, where should we apply the pump? Okay. Where should we apply the pump? We should apply the pump in the shoulder, upper arm, and abdomen. Okay, shoulder, upper arm, and abdomen. That will covered by the short sleeves or t-shirt. It should always be covered because others should not get the gel which you have applied. Okay, do not apply androgel to any part of your body such as breast. You do not have to apply it in the breast, thighs, chest, back. Before applying androgel, make sure that your shoulder, your upper arm, and abdomen are clean, dry, and there is no broken skin. Apply androgen 1% at the same time each morning. Androgel 1% should be applied after showering or bathing. Wash your hands right away with the soap and water after applying androgen 1%. Androgen 1% is a flammable until dry. Let androgen 1% dry before smoking. You shouldn't be smoking in the first place, but if you are using androgen 1%, you'll have to make sure that it has already been dried, because the androgen is a flammable substance, or you don't have to go near open flame. Let the application area dry completely before putting on a t-shirt. Do not use androgel 1% for longer than 3 weeks. Okay, patient preferred for testosterone use are poor responders. Women with low response to the ovarian stimulation are classified in the poor responder under Bologna or Posidian criteria. And second is older women, especially more than 35. Okay, because women has age related decline in androgen, they will benefit more. Okay, when not recommended, when you already have more androgen level, like PCOS patient, then the androgen is not recommended. So according to the ASHA 2020 guidelines, state that use of testosterone pre-treatment for poor responder is probably not recommended until further randomized evidence become available. Now, growth hormone. Growth hormone is an anterior pituitary hormone with 191 amino acid that has several key role in growth and development, but also has been shown to be an important contributor to two things. First is ovarian steroidogenesis. What is ovarian steroidogenesis? Means synthesis of ovarian steroid. Synthesis of ovarian steroid like progesterone, estrogen. Second is folliculogenesis. Okay, so growth hormone help in ovarian steroidogenesis and folliculogenesis, follicular development. Now, what is the mechanism of action? Growth hormone stimulate the production of IGF-1. What is IGF-1? It is insulin-like growth factor 1 within the ovary. Why is IGF-1 important? It plays important role in ovarian function. First is ovarian function. It plays important role. Second, follicular recruitment. Follicular recruitment. Third is protection from apoptosis. Apoptosis is cell death. So it will protect from apoptosis. Fifth is estrogen production. As we already talked that it helps in ovarian steroidogenesis. So it helps in estrogen production. Fifth is oocyte maturation. Ensure the egg is properly developed. Overall effect is it improves both quality of egg and quantity of egg. Quantity means more egg are recruited for ovulation. Okay, now endometrial effect. What happened in the endometrium? Growth hormone acts through local within the uterus and systemic through whole body. It acts through both local and systemic pathway. So basically, growth hormone stimulate IGF-1, VEGF, vascular endothelial growth factor, and ITGB3, integrin beta 3, okay, pathway, which are key for implantation. So VEGF basically will improve the angiogenesis, and ITGB3 will be used in cellular adhesion. Now, there are two effects, direct effect and indirect effect. Direct effect is it will improve vascularization, vessel formation, okay, and will enhance the embryo adhesions. Embryo will adhere, embryo adhesions. And indirect effect is it support the corpus luteum. See, it support the ovary will be there, so it will support the corpus luteum. That is indirect effect, which produces the progesterone. With the progesterone, you already know is a pregnancy hormone. This is a steroid hormone, pregnancy hormone. Now, vascularization and blood flow. What happens is growth hormone increases the VEGF. Growth hormone will increase the VEGF production. VEGF production, which improves the blood supply to the uterus. Why is this important? Better blood perfusion ensure the uterine lining is healthy and ready for implantation. Okay. Now, endometrial thickness and receptivity will also be increased. Okay. And a thick and receptive endometrium is critical for embryo implantation and pregnancy success. Higher implantation rate. Growth hormone enhances the implantation rate by increasing the expression of integrin beta 3. It also stimulate other implantation related gene. Okay, integrin beta 3 plays a key role in helping the embryo to attached in the uterine wall. Okay, now we'll see it with the help of one diagram. See, growth hormone is basically produced by anterior pituitary. We already know it can also be produced locally in a small amount within reproductive tissue like ovary and uterus. Okay. Now see, we'll see that three things we can see: liver, ovary, and endometrium. Liver, ovary, and endometrium. First, liver. Growth hormone stimulate liver to produce IGF-1. This IGF-1 then released into the bloodstream and act on the ovary and endometrium. Okay. Now in ovary itself produce IGF-1. So in ovary, growth hormone receptor is expressed in the granulosa cell. Okay. The growth hormone receptor is present in this is granulosa cell. Growth hormone receptors are present in the granulosa cell. So growth hormone and IGF stimulate the progesterone production. See, growth hormone in ovary, growth hormone and IGF-1, growth hormone and IGF-1 stimulate the production of progesterone. Stimulate the production of progesterone. And in endometrial epithelial cell also expresses growth hormone receptor. Okay, so IGF-1 in endometrium in growth hormone stimulate the production of IGF-1 in and within the endometrial cell. There will be improved blood perfusion through VEGF. See, through VEGF, there will be improved blood perfusion. This is blood vessels, okay? And there will be increased thickness of the uterine lining, and there will be greater expression of VEGF and integrin beta 3, which will also improve the uterine receptivity. So basically, there will be more implantation rate and pregnancy rate, okay? And uterus will become more receptive, more pregnancy rate and higher implantation rate. Now see, this signaling pathway act through three pathway. This growth hormone act through three signaling pathway. One is JAK2 STAT pathway, another is MAP kinase pathway, and another is PI3K pathway. So JAK2 STAT pathway, basically these all pathway will produce this targeted the gene that are IGF-1, VEGF, and integrin beta 3 and other targeted genes. Diagram is of there was some studies done in the in vitro maturation. Influence of growth hormone on oocyte in vitro maturation means actually oocytes are not mature, and in those we did studies for the effect of the growth hormone. So this diagram illustrates that growth hormone enhances the oocyte quality through various mechanisms. First, it binds to the receptor and it triggers multiple cellular processes. It reduces CAMP. First is it reduces CAMP level, which accelerates meiosis. Okay, which accelerate meiosis. So this will ensure faster nuclear maturation. Okay, and so oocyte quality will be better. Growth hormone decreases apoptosis. See, growth hormone decreases apoptosis and also decreases DNA damage, protecting oocyte developmental potential. In mitochondria, growth hormones improve mitochondrial function by reducing reactive oxygen species. Okay, and oxidative stress, while it also lowers the calcium level. See, it is lowering the calcium level. See, elevated calcium disrupt the MMP. MMP is elevated calcium disrupt the MMP. MMP is mitochondrial membrane potential. This will impair the ATP or energy production. Okay, so this will disrupt the metabolism in the oocyte. So basically, I think this sign should be upwards because increased mitochondrial membrane potential is associated with better energy production, better energy. So I think this diagram should have arrow upwards. Okay, so basically it helps in increasing the oocyte health and quality. Okay, now we'll talk about dosing or doses of the growth hormone. Okay, so in ART, the doses of the growth hormone is adjusted based on the patient's need. Okay, generally a dosage of 4 to 8 international unit is prescribed. Okay, but in some cases it can go to 24 international unit on alternate day. A common practice is to use 0.1 international unit per kg per day along with gonadotropins like HMG until the ovulation trigger. Growth hormone is administered subcutaneously, which means it is injected just under the skin. The timing of the growth hormone is important. It is usually started on the day 2 or 3 of control ovulation stimulation and continued till the ovulation trigger. Sometimes growth hormone is started 7 days before the gonadotropin stimulation as a pre-treatment. Growth hormone is often combined with gonadotropins, FSH. gonadotropin FS to optimize ovarian stimulation protocol. Intrauterine administration of growth hormone as per the protocol by you et al. Right now, I'm talking about growth hormone in thin endometrium. Okay, we are slightly deviated from the topic, but growth hormone is also important for thin endometrium. So I just wanted to discuss the doses. There was a study by you et al. In 2016, so in which the treatment involves 4 to 5 intrauterine perfusion of 6 international unit growth hormone diluted in 0.5 ml saline administered on day 9 to 12 of menstrual cycle. After each perfusion, patient was advised to take 15-minute bed rest. This approach significantly improved the endometrial thickness. So not only in the poor responder, growth hormone is also helping in the thin endometrium. So the endometrial thickness was increased and there was enhanced in the endometrial receptivity. See, 3 molecular pathway we have already talked about. First is VEGF. It improves the vascularization and essential for implantation. Second is integrin beta 3. It facilitates embryo for adhesion to the endometrium. Third is IGF-1. It mediates cellular growth and proliferation and vascular development. Now, growth hormone used in ART. Okay. What are the potential benefit of growth hormone in ART? While human growth hormone has been explored for thin endometrium and recurrent implantation failure, the evidence in this area remain limited and experimental. So for poor responder, human growth hormone shows promising in improving live birth rate, reducing the gonadotropin use. Okay. According to study, it will increase the live birth rate and the doses for gonadotropin will reduce. Like we have to give lesser doses of gonadotropin. These are according to studies, and there were more oocyte yield during IVF cycle. However, the evidence is inconsistent and due to higher cost and the side effect, its routine use is not recommended outside the clinical trial, and we need more well-designed studies to confirm its benefit and standardized protocol. Now for normal responder, like we also use growth hormone in normal responder, especially in women over 35 year with declining IGF-1 level and diminished ovarian reserve. Actually, IG1 level decreases with age, and women with IG1 level less than 20 nanomole per liter and a high, this is decrease in high IGF beta P3 by IGF-1 ratio. What is IGF beta P3? Insulin-like growth factor binding protein 3. If this ratio is more than equals to 5, the patient may benefit from the growth hormone supplementation to improve fertility. This was written in this study. Okay, this was written in this 2019 study. Now, growth hormone are also used for low quality embryo. It basically improves the quality of the embryo. So despite its potential, the 2020 ASHRAE guideline recommends caution in using growth hormone for poor responder, stating it is probably not recommended in such cases. More research is required to validate its efficacy and establish its use as a standard practice in ART treatment. See this, we can see the diagram. This is the growth hormone. This is used subcutaneously. It is 4 international unit. As we have already talked, we use either 4 international unit to 8 international unit per day, or we use 24 international unit alternate day, or 0.1 per kg. 0.1 international unit per kg. Now we'll come to antioxidant. Antioxidants play a critical role in improving the oocyte quality and IVF outcome by decreasing the oxidative stress, which results from elevated level of reactive oxygen species. Now, what is reactive oxygen species? Reactive oxygen species is the byproduct of aerobic metabolism, which leads to DNA damage, lipid peroxidation, and apoptosis in oocyte. Especially it occurs during oocyte stimulation when antioxidant capacity is reduced. Okay, antioxidants work by, how does it work? It works by scavenging reactive oxygen species and protecting oocyte from oxidative damage, and are derived from both endogenous production. Even antioxidants can also be made by our body, or exogenous supplementation, or we can take the supplementation. Okay, now we'll see one diagram. See, this diagram highlights the factor contributing to oxidative stress in the oocyte, including atmospheric factors like light, temperature, ambient air means increased PO2. Okay. Culture associated factor like nutrition deficiency and decreasing signaling factor, and oocyte associated factor like mother's age and oocyte post-ovulatory aging means more mature oocyte. Okay, this all will increase ROS in oocyte and culture media. This imbalance between ROS and antioxidant less leads to spindle formation error, increase protein lipid DNA damage, increase mitochondrial dysfunction, decrease oocyte maturation. Okay, from this diagram, we can easily understand what's happening. Now, see factors impacting oocyte. See, oocyte quality is impacted or influenced by several factors, including advanced age, okay, endometriosis, gonadotropic therapy. These all can increase the risk to oocyte. Okay. Now, while low ovarian reserve does not always mean poor oocyte quality. Means if they have a lesser ovarian reserve does not always mean that they have a poor oocyte quality. These factors significantly increases the risk, like increasing age, gonadotoxic treatment, and endometriosis significantly increases the risk of having a poor quality embryo. Okay. Now, oxidative stress. Oxidative stress caused by reactive oxygen species generated during the cellular metabolism. Stress. Cellular metabolism. Okay. Due to cellular metabolism, reactive oxygen species were generated, which led to oxidative stress. Now, what will happen? This will lead to DNA damage. DNA will get damaged. This will lead to lipid peroxidation, and this will lead to lipid peroxidation, and this will lead to protein damage. Protein will also get damaged. These effects inhibit oocyte development and causes, like I have already shown, meiotic arrest, and led to apoptosis, significantly impacting the fertility outcome. Antioxidants play a crucial role, vital role in combating or decreasing oxidative stress by scavenging ROS. We have already talked, and preventing cellular damage. Example includes vitamin E, C, D, B complex, folic acid, omega-3 fatty acids, coenzyme, melatonin, selenium, L-arginine, myo-inositol. These antioxidants can produce naturally or administered externally. Either it can be produced by the body or it can be given by the supplement externally to improve the IVF outcome. Now, randomized controlled trial RCT has demonstrated the effectiveness of CoQ, melatonin, and L-arginine in improving outcome for poor ovarian responders, providing evidence for their use in ART protocols. So, in this today, we'll talk about three antioxidants. Okay, CoQ, 10, melatonin, and L-arginine. Okay. See this diagram. See, this diagram explains the impact of oxidative stress, ROS, on oocyte development and embryo production during ART, including in vitro maturation, in vitro fertilization, and in vitro culture. What happens? Okay, it will tell what it tells about in vitro maturation, in vitro fertilization, and in vitro culture. So first is role of ROS during oocyte collection and maturation, exposure to oxidative factors like light. See, light. Can you see? Light. Okay. O2, oxygen level, and culture media cause an imbalance between ROS production and elimination. Okay. Now, excess ROS such as superoxide ion, hydroxyl radical, and hydrogen peroxide leads to oxidative damage affecting critical cellular component. Now, oxidative stress effect on mitochondrial dysfunction. See here, we can see mitochondrial dysfunction. This will reduce the ATP production and impair the energy supply, which is essential for oocyte maturation and development. Second is calcium imbalance. There will be altered calcium homeostasis. Altered calcium homeostasis will actually disrupt the cellular signaling. Okay. Then is membrane fluidity and microtubule dynamics. See, decrease membrane fluidity and impaired microtubule dynamic. So impaired function disrupt normal cellular process like spindle formation. Microtubule dynamic will be altered, then spindle, there will be difficulty in spindle formation and chromosomal segregation. Okay, and DNA fragmentation and apoptosis. There will be fragmentation of the DNA and there will be apoptosis. Okay, and now these two part of the diagram we have already understood. This part and this part of the diagram we have already understood. Now impact on the IVM. What will happen in the IVM, in vitro maturation? ROS causes spindle formation error. Now there will be error in the spindle formation process and there will be chromosomal aneuploidy. There will be chromosomal aneuploidies and abnormal distribution of the cellular organelle and increased apoptosis. There will be increased apoptosis leading to poor oocyte quality. Now we have talked about this. Now we'll come in IVF. Okay. Impact on IVF. High ROS level will impair membrane fusion during sperm oocyte interaction and there will be decreased oocyte activation. So neither it will lead to the, it will disrupt the membrane fusion and it will also disrupt the oocyte activation in the IVF. This also we have done. Now we'll talk about IVC, in vitro culture. Oxidative stress negatively impact the development embryo, leading to a lower blastocyst yield and quality. Number will also decrease and quality will also decrease. Okay, quality. Along with potential epigenetic alteration, there will be epigenetic alteration which can affect long-term embryo health. Okay, this will affect long-term embryo health. So role of antioxidants are antioxidants in the follicular fluid and optimized culture condition can help to decrease the oxidative damage and improve the oocyte and embryo quality during ART. Now we'll talk about another diagram. This is antioxidant property of molecule. Okay. See, this diagram shows how various antioxidants like coenzyme Q, vitamin E, folic acid, resveratrol, and melatonin work together to combat, to fight ROS, reactive oxygen species, which causes oxidative stress and damage to the cell, especially to the mitochondria. So, how these antioxidants are saving the mitochondria? See. See, what is the role of mitochondria first? Okay, mitochondria is the powerhouse of the cell, which is essential for energy production. However, they also produce ROS, reactive oxygen species, as byproduct. If ROS level become high, they will damage DNA, protein, and the membrane, leading to oxidative stress and poor quality oocyte. Okay, there should be a balance between ROS and antioxidants. So how antioxidants work? See, coenzyme Q found in the mitochondria, it stabilizes the electron transport change and reduce ROS production. So electron transport change basically is very important for energy production. So CoQ enzyme ensure that efficient energy production and good oocyte quality, and it will improve the health of mitochondria basically. Okay, now what will happen in, what will vitamin E do? Vitamin E, see, as we can see, this is sign is for protection. So vitamin E will protect the cell membrane by preventing lipid peroxidation by ROS. Okay, then what will folic acid do? Folic acid basically, it plays a role in DNA repair and stability, helping cell recover from the oxidative stress. Now, what will resveratrol do? See, resveratrol is found in foods like red grapes. So, resveratrol activates SIRT1 pathway that enhance the production of antioxidant gene. Okay, so this boosts the cell ability to produce its own antioxidant, providing long-term protection. Okay, now what will melatonin, ascorbic acid, okay, first melatonin, what will it do? It directly neutralizes the ROS. See, both the action of melatonin, ascorbic acid, and vitamin A is directly neutralizing the ROS. Okay, another action of melatonin is it also activate antioxidant gene. See, it is also activating antioxidant gene. Can you see? Melatonin is here also, and here two type of function. This antioxidant gene is produced by melatonin, and this direct neutralization of ROS that will reduce the oxidative stress is also happening through the melatonin, and this is also happening with the ascorbic acid and vitamin A. Directly, they are inhibiting the ROS. We'll talk about coenzyme Q. Coenzyme Q work as a strong antioxidant that plays a key role in protecting oocyte from oxidative stress and DNA damage, preventing apoptosis, cell death. Okay, it helps maintain energy production in the mitochondria, which is crucial for healthy oocyte, as we have already discussed. It is recommended at a dose of 600 milligram per day, usually divided into 3 doses of 200 milligram each for 2-3 months before starting stimulation. It is beneficial for women aged 35 to 43 years undergoing ART, especially those with age-related oocyte quality decline or mitochondrial dysfunction. Okay, age-related oocyte quality decline and mitochondrial dysfunction. It is also helpful for poor responder age 36 to 40 year, which fits into the Bologna criteria. It also helps in young poor responder aged less than 35 year with diminished ovarian reserve. Okay, Positidian group, which has Positidian group 3 means young. Okay, young but has diminished ovarian reserve. So Positidian AMH is less than 1.2 nanogram per ml and AFC is 5. That means Positidian group 3. It is also it is also helpful in women suspected to have oocyte quality issue due to oxidative stress or mitochondrial dysfunction. If some women is suspected to have more oxidative stress and mitochondrial dysfunction, those women can also use the coenzyme Q. Now we'll talk about the melatonin. Melatonin is a hormone naturally produced by the pineal gland, and that regulates the sleep-wake cycle, like circadian rhythm. Okay, it acts as a strong antioxidant by targeting MT1 and MT2 receptor, protecting ovarian follicle from oxidative stress and damage. And it also decreases the follicular atresia. Okay, the recommended dose is 3 milligram per day. See, melatonin. Now, melatonin, if we'll rotate it, it will become 3. So this way we can remember the dose of the melatonin. It is 3. Remember, it is milligram per day. Okay, taken at night. Why is it taken at night? Because we take melatonin for sleeping also. Some people who are having sleeping problem can take melatonin for sleeping also. So it basically induce sleeping. So it is taken at night, starting from the 5th day of the previous menstrual cycle. 5th day of the previous menstrual cycle and continued until the day of oocyte retrieval. During ART, it is suitable for general ART population, including women with or without sleep issues, and particularly for poor responders with diminished ovarian reserve. Okay, it can be also be given to the general ART population, and it can also be given to the poor responders, especially the women with diminished ovarian reserve, defined by AMH less than 1 picogram mole per liter, AFC greater than 10 international unit per liter, greater than equals to, and bilateral AFC less than equals to 6. Clinical study shows melatonin improve the quality of M2 oocytes and embryo. However, no significant improvement in pregnancy rate has been observed, even with the higher doses of 4 milligram and 8 milligram per day. So now we'll talk about the L-arginine. So arginine is basically an amino acid that act as a precursor for nitric oxide synthesis. Okay, this improves the ovarian nitric oxide synthesis. Nitric oxide is basically for vasodilatation. So this will improve the L-arginine will improve the ovarian blood flow. Okay, so this folliculogenesis will be improved, and there will be oocyte maturation. The recommended dose for L-arginine is 16 gram per day. How will we remember 16 gram per day? See, in a chessboard, this is a chessboard. In a chessboard, each player start with a 16 pieces of chess. 1, 2, 3, 4, 5, 6, 7, 8. So 8 to just 16. So we'll remember by visual mnemonics. See, this I have kept L-arginine here, and this is over the chessboard. So chessboard players start by 16 pieces in the chess. Okay, each player starts with 16 pieces in the chess. So we'll remember L-arginine dose by remembering this picture mnemonic. Duration is, it is taken during the ovarian stimulation until the day of oocyte retrieval. It is primarily suggested for poor responder. It is primarily suggested for poor responder, especially women with a history of cancelled ovarian stimulation due to low serum estradiol level, that is less than 1100 picomole per liter, or when cancellation happened because of fewer than 3 follicle on stimulation day 8. Okay, clinical evidence is limited. A single study indicate an increase in oocyte retrieval with this regimen, but further research is required to validate this finding and refine doses protocol. Thank you.